Hello, my name is Craig Blackwell. I'm an ophthalmologist in Santa Cruz, California. This is the first of a series of videos about glaucoma. In this video, we are going to talk about diagnosis of glaucoma. Remember, this is for your information and does not substitute for evaluation by your own ophthalmologist. In simplest terms, glaucoma means that there is damage to the optic nerve that comes from elevated pressure within the eye. We will now attempt to explain what that means. Let's get started by getting oriented to the eyeball. Here is a diagram of selected parts of the eye. Light enters the eye through the cornea and lens and falls on the retina, where the rods and cones record an image like film in a camera. Nerve fibers coming from the rods and cones travel along the surface of the retina and are gathered into a bundle which makes up the optic nerve. The optic nerve contains about 1 million individual nerve fibers, which then act as a telephone cable back to the brain. Here is a view looking through the pupil into the eye. The round yellow disc is the head of the optic nerve as it enters the eye. You can see the veins and arteries as they branch out from the center of the nerve. The rest of the inside is lined by the retina. The eyeball requires a certain amount of pressure to keep it inflated and functioning well, like in a tire or a basketball. To maintain pressure, fluid is constantly pumped into the eye by the ciliary body located just behind the iris. That fluid is called aqueous humor. It is filtered from blood and it brings oxygen and nutrients the inside of the eye needs to function. Here is a close-up diagram of the front of the eye. Picture it like the front of a watch. The cornea is like the crystal of the watch and the iris is like the face of the watch. In between, there is a space called the anterior chamber, which is filled with watery aqueous liquid. Where the cornea and iris meet is called the angle of the anterior chamber. The angle is going to be important for us in a couple of ways. To see how, let's follow the circulation of aqueous in the eye. Remember, aqueous is pumped into the eye by the ciliary body. After circulating around the lens and through the pupil, it enters the anterior chamber. It leaves the eye through a filtering system called trabecular meshwork, located in the angle. After passing through the meshwork, it is carried back into the bloodstream by the canal of Schlemm. Under a microscope, the meshwork looks like pores in a sponge. Usually, the amount of fluid entering the eye balances with the amount leaving the eye, and the level of pressure stays constant. As the years go by in everyone's life, the filtering system gradually decreases in function, which makes it more difficult for the fluid to exit the eye. Since the aqueous has a harder time getting out, the pressure inside the eye gradually rises. When pressure rises enough to cause damage, despite unobstructed access to the filtering system, it is called open-angle glaucoma. This accounts for about 90% of glaucoma. The other common type is called narrow angle. It is responsible for most of the remaining 10%. On the right side of this diagram is the open angle, with plenty of space for the aqueous to reach the meshwork. On the left side, you can see the iris is pushed forward, leaving only a narrow slit for aqueous fluid to reach the meshwork. If the iris moves any farther forward, it would block access to the meshwork. And if aqueous can't get to the meshwork, it can't get out of the eye, and pressure rises. This is what narrow angle glaucoma is, and it is covered in a separate video. Testing for glaucoma requires 3 basic things. 1 is measurement of pressure, 2 is evaluation of the health of the optic nerve, and 3, if pressure is elevated, is there a special reason why, like a narrow angle, or extra pigment, or exfoliation syndrome? Are there medications like prednisone causing an increase in pressure? An instrument that measures pressure is called a tonometer. Here is a Goldman tonometer in position in front of the eye about to measure pressure. After instilling anesthetic drops, the lighted blue tip is pressed gently against the cornea. The pressure reading is taken from the dial in the lower center of the picture. If you measure pressure in a lot of people, the average is 16, with a normal range up to about 20. There are 2 important things you need to understand about eye pressure. First is that eye pressure is quite variable. Even within a 24-hour period, it commonly varies 3 to 5 points. So at a single pressure check, you don't know if you are at the high end, low end, or middle of your range. Second, and very important, the amount of pressure it takes to do damage in a specific person varies widely. Some people have optic nerves that are particularly resistant. They can tolerate a pressure in the mid-20s without damage, while others have more fragile nerves that can have damage in the middle teens. One technical point. The pressure reading from the Goldmann tonometer is affected by corneal thickness. Just like people vary in height, so does the thickness of the cornea. So we measure the thickness of the cornea using ultrasound with this instrument called a pachymeter. Then we add or subtract a correction factor to get a more accurate measure of the true pressure inside the eye. Regarding the optic nerve, there are two ways to measure damage. One is to look for structural changes in the nerve, and the other is to look for functional changes. Let's look at both of these. On the left is a photo of a normal optic nerve. The nerve fibers are located in the orange-colored rim. The paler center is the cup, kind of like the hole in the center of a lifesaver. Note the orange rim is even all the way around. When there's damage, nerve fibers are lost and the rim gets thinner. This photo shows a nerve with a lot of rim tissue loss, representing fairly advanced damage. There are several instruments available to help measure changes in the optic nerve. This is the full printout from a machine called an HRT, which gives us a detailed contour map of the optic nerve with a number of specific measurements that help us decide about the health of the nerve. Here is part of the HRT printout for the damaged nerve in the previous photo. On the left is a contour map. The blue-green is the rim, the red is the central cup. I have added the white arrows pointing to the thinned areas of the rim. On the right, the computer has divided the nerve into sections and compared each section to the normal range. The green checks mean within normal range, the yellow exclamation mark means borderline, and the red X's mean out of normal range. In this nerve, the rim thinning is obvious, but the HRT is very helpful in finding early damage and for looking for change over time. The other part of assessing glaucoma damage is to measure the function of the nerve by checking peripheral vision. One of the sneaky things about glaucoma is that it takes peripheral vision first we are not likely to notice. Only when it is far advanced does it affect central vision. The test that measures peripheral vision is called a visual field. This is part of a visual field printout. Where the lines cross is the center of vision. This is a left eye, so the normal blind spot is on the left side. On a grayscale diagram, a normal field should be light gray overall. The darker gray and black shading indicate degree of damage. Specifically, the darker the shade, the more the damage. Damage meaning vision loss. One tricky thing about visual fields is their variability. If you came in for a field test once a week, each one would look somewhat different, partly because of how you are responding to the test on a particular day, and possibly because the optic nerve may vary in function. Here is how it all comes together. The part of the nerve with more damage labeled A on the HRT corresponds to the advanced field defect in the upper part of the visual field. The part of the nerve with the borderline reading labeled B corresponds to the moderate damage in the lower field. In studies of optic nerve in glaucoma, it has been shown that one has to lose a quarter to a third of the optic nerve fibers before a defect shows up on the visual field. In theory, that makes the optic nerve structure test the more sensitive detector of early damage. Here's a good place to make a point about terminology. When the eye pressure is above the normal range but has not yet caused damage, we use the term ocular hypertension. Once there is damage, then we use the term glaucoma. In the next video, we will cover treatment of glaucoma.